let's move to the second topic. The second topic is approach to pediatric chest in ER, and the speaker is Dr. Kushaljit Singh Sodhi. He is an professor at Department of Radio Diagnosis and Imaging, postgraduate Institute of Medical Education and Research from Chandigarh, India. Please welcome Dr. Sodhi.
Thank you, Supika, for the introduction. I would like to take this opportunity to thank the Royal College of Radiologists of Thailand as well as AOSOR for having this session and inviting us all here. All right, I just wanted to make sure it works. So just to give you a brief layout, I'm from one of these apex tertiary care hospitals in northern part of the India, which is called PGI MER. So as far as radiological armamentarium or diagnostic images for pediatric chest is concerned, we have a whole gamut of them, starting from chest X-ray, fluoroscopy, ultrasound, contrast study, CT and MR. But by and large, what we do in our daily practice usually involves a chest X-ray, ultrasound, CT or MR, and I'm going to show you some examples as we go by. So approach to a pediatric chest in an emergency radiology room or an emergency room setting would, of course, we're talking of a non-traumatic chest here, right? Would involve upon the age of the child and the clinical profile or the history. But we need to keep the ALARA principle, that is as low as reasonably achievable principle for radiation dose in children specifically in mind, so that we do not order too many of CT scans where we can avoid them. So thoracic emergencies in children of different ages can be broadly divided into a neonatal group, which is called as a neonatal respiratory distress, or an infant group. I think I don't need to stand on this, okay. Or an infant group, or we can divide into preschool age 1 to 5 years, or the school age group 5 to 10 years. So what we shall cover today briefly in the next 20-25 minutes is going to be a brief layout of spectrum, taking through all the medical and surgical causes of the main causes of neonatal and other causes of respiratory distress in a child. And I'm going to show you 10 case-based reviews, very fast spotters-like thing in the end. Thank you. So briefly, we can divide the thoracic emergencies in children in different ages according to these broad categories, such as congenital anomalies, which you would obviously see more common in a neonate or infant or in the early preschool 1 to 5 years. Infections can be seen across through all age groups, even infant or even older kids. Foreign bodies are typically seen in children and can bring a child to the ER, but the age group is slightly older child, like 2 years, 3 years, when the child starts to move around and starts to put things in their mouth. And of course, air leak and tumors. Tumors are uncommon in infants, although you could have lymphoma, leukemias, neuroblastomas, even in infants, but they are by and large and after one years of age, the more commoner ones. So let's start with thoracic emergencies in neonates. So neonatal respiratory distress, as called, it occurs nearly 11 to 14% of all live births, and incidence depends on the gestational age. More the child is a preterm, the higher the incidence of a neonatal respiratory distress in the child. So broadly, we can divide these into two broad categories for simplification, and also as the mode of management. You can have a medical disease spectrum, which is typically managed medically, and a surgical disease spectrum, which is managed surgically. And you have these broad entities. I'm going to cover most of them just to show you one or two more examples of each of them. So let's start with the medical disease spectrum. The first or the top of the list is a hyaline membrane disease, which is also known as surfactant deficiency syndrome, as the name implies, because of lack of a surfactant. And this is typically seen in a premature infant. So this is the most common cause of respiratory distress in as many as 60% of babies born before 29 weeks of age. And remember, this develops typically before the neonate is 4 hours old and persists more than 24 hours of age. I'm going to tell you why this is important in a couple of slides as you go by. So remember, this persists more than 24 hours of age. So typically, a chest X-ray findings, you have this reticulogranular appearance, or also described as a ground glass appearance on a radiograph, but the lungs are hypovolumic. If there is one sign which excludes a hyaline membrane disease, it's a hyperinflation. So if in a premature kid you have a hyperinflated X, that by and large excludes a hyaline membrane disease, because in a hyaline membrane disease, because of lack of surfactant, there is hypovolemia, right? So you can't have hyperinflation of the lung, and pleural effusions are seldom seen. So these are two common examples or two broad spectrums. Okay. So the one on your left-hand side, you can see complete whiteout of the lungs, bilateral, almost complete whiteout or opaque lungs, right? And this is a less opaque lungs, but you still have this bilateral reticogranular appearance. So these are two broad spectrums of a hyaline membrane disease typically seen. And what happens in the hyaline membrane disease, once you give surfactant, there is a rapid response. So if you look at this first radiograph, you have a reticogranular appearance of the first chest X-ray on day 1, and after 18 hours, is limping back to normal, pretty fast, I would say. So is there any role of ultrasound? Yes. So there are a lot of studies looking at the role of ultrasound in hyaline membrane disease. So what you can do actually in ultrasound is, as seen in the X-ray, so there's a specific finding here that is increased retrodiaphragmatic hyperechogenicity, which is seen in a hyaline membrane disease, which is said to be very highly sensitive and specific for this particular disease entity, and you can use this for follow-up of hyaline membrane disease and for prediction of bronchopulmonary dysplasia as well. Just to illustrate this point, this is how a normal diaphragm would look like. This is increased retrodiaphragmatic echogenicity in hyaline membrane disease, and if it persists into a bronchopulmonary dysplasia, this becomes more heterogeneous and breaks in between. That's how on ultrasound you can actually follow up these patients for hyaline membrane disease, whether they are going to go back to normal or hyaline membrane disease. So transient tachypneic newborn is another entity seen in neonates or seen as wet lung. So typically the lungs are hyperinflated, and it typically resolves within 1 to 2 days of life, right? Meconium aspiration syndrome is another entity which affects term and post-mature neonates. This is not seen typically in the preterm, so this is term and post-term babies. And typically, as you can see here, you have hyperinflation, coarse capacities, no effusion, and you could have a spontaneous pneumothorax. So pneumothorax in neonates is also a particularly very important entity. It can be spontaneous or secondary to infections, meconium aspirations, or ventilation barotrauma. And spontaneous pneumothorax is obviously more commoner in premature babies as compared to term babies. Another important reason why a child could come to the ER or comes as a respiratory distress is infections or neonatal pneumonias. There are various organisms. Chest X-rays can pick up pulmonary opacities, consolidations in different spectrum, and they're by and large very non-specific as far as the radiograph is concerned. So moving on from a medical disease spectrum to a surgical disease spectrum. So how do you approach for the surgical disease spectrum in a child? Remember, the chest X-ray is always the first one to be done, so it kind of picks up a lesion, it detects a lesion, but you would need a CT scan or MRI for diagnosis, to localizing it, and for pre-surgical roadmap or pre-operative evaluation of this. So as far as congenital anomalies are concerned, there is a long list depending upon if the lungs are involved. So you could have pulmonary agenesis, aplasia, or hypoplasia. Or you can have a CPAM, congenital pulmonary airway malformation, congenital lobar overinflation, sequestration, diaphragmatic hernia, and a vascular rings and slings. I'm going to show you at least 1 or 2 examples of each one of them. So let's start with the pulmonary agenesis, aplasia, hypoplasia spectrum. So this is how they are going to look like typically on an X-ray and a cross-sectional imaging. So you have agenesis, aplasia, hypoplasia. And what is the difference between these three is you need to look at the main bronchus, part of the lung, as well as the pulmonary artery. If you do not see the bronchus is absent, pulmonary artery is absent, and the lung parenchyma is also not seen, you're dealing with an agenesis. However, if you see a rudimentary bronchus, as you can see in this one, but you don't see the pulmonary artery, you don't see the lung parenchyma, it falls in the aplasia segment. Hypoplasia is kind of dicey because you see a bronchus, its only thing is it's small bronchus, slightly smaller lung parenchyma, and a smaller pulmonary arteries, right? So this is to differentiate between agenesis, aplasia, and hypoplasia spectrum. Moving on to CPAM, which is a congenital pulmonary airway malformation. which results from failure of the bronchoalveolar development. And there are types of CPAP have been described, the famous Stalker classification, which has been revised. That revision also took at least a decade back, I will say. So there are five types now, right? So ranging from 0, 1, 2, 3, 4, I'm going to show you some examples as we go by. So most common is the type 1, in which you see large air-filled cystic spaces. So these typically comes with respiratory distress after birth, and the radiological findings, as you can see on this one, can be a cystic or hyperlucent lung on a chest X-ray, but multiple large air-filled cysts seen in a single lobe and unilateral more commonly. So type 1 is a large, as you can see here, large single air-filled cyst space. If there are multiple smaller, less than 2 centimeters, this is a type 2. The solid one is called a type 3, and sometimes you could have this type 4, which is almost indistinguishable on a CT scan from a pleuropulmonary blastomas. So these are by and large the 4 types, but remember the type 1 is the most commonest one, followed by type 2. Moving on, congenital lobar emphysema was the earlier term. Nowadays it's called as congenital lobar overinflation or hyperinflation. This is also pretty common, which results from progressive overdistension of a pulmonary lobe and is involved with either intrinsic or extrinsic compression. And it is not necessarily lobar, it can be multi-lobar also, but that is also less common, or I would say even rare. So remember, there are different sites which can be involved, but the most common site is the left upper lobe, followed by this right one here, and then the right upper lobe. The lower lobes are less commonly involved or rarely involved in a congenital lobar hyperinflation. So what are the radiological findings? Typically in a chest X-ray, you find a hyperinflated lobe which becomes hyperlucent. There's less vascular markings. Pulmonary vessels appear attenuated, and the surrounding pulmonary vessels are displaced. And remember, the adjacent lung that is compressed and mediastinum can be shifted to the opposite side. So this is how a typical chest X-ray would look like. And on a CT scan, you can see this hyperinflated particular lobe with attenuation of the pulmonary vessels. Another example to show you a congenital lobar overinflation or a hyperinflation. Moving on to congenital diaphragmatic hernia, which I would say radiologically would be the easiest to pick up on even on a plain radiograph. So this results from an abnormal development of the diaphragm. And this can be a apostolic hernia, Morgagni hernia, or a central defect, depending upon if it's on the right side or the left side, and if the defect is anterior or posterior. The major causes of demise of a child results from pulmonary hypoplasia and pulmonary hypertension in these children. The key points is in the early film, early radiograph taken just at birth, what you're going to see is a radio-opaque hemithorax, like the top one like that. It almost looks, somebody might call this as a fluid as well as an effusion, right? Because this is because of fluid-filled or collapsed bowel. But if you see a later film done at 24 hours of age or at 48 hours, you can see this gas-filled bowel loops. So now in this bottom X-ray, the diagnosis is pretty straightforward. Multiple gas-filled bowel loops in the chest, diaphragmatic hernia, right? So to illustrate, this is the first X-ray at birth. This looks like an opaque hemithorax. But if you look after 24 hours, all bowel loops. So sometimes it makes sense to just repeat a radiograph after 24 hours just to make sure we're dealing with congenital diaphragmatic hernia. So moving on to another spectrum, which is a vascular malformation or a congenital vascular malformation, which can also give you the tracheobronchial obstructions. And the radiological investigations of choice are CT angiography or MR angiography. Again, it depends on institutional practices and guidelines which you follow in your own hospital settings. So we have a typical what is described as the rings and slings. The vascular rings come from the anomalies of the aortic arch or the great vessels, while the pulmonary rings are anomalies of the pulmonary arteries, as the name indicates. All right. So what are rings and slings? I'm going to show you some examples. The vascular ring is defined as abnormal encircling of the airways, that is the trachea, and as well as the esophagus, by the aortic arch and its branches as well. So the most common vascular ring is a double aortic arch. Second most common is a right aortic arch with an aberrant subclavian artery with an intact ligamentum arteriosum. So this is how a double aortic arch is going to look like because of the embryological persistence of both sides of the arch. So you have two arches encircling the airways, and if you do a volume rendered images, it comes up beautifully like this ring, right? So that's why it's called a ring. So this is a double aortic arch in a 2-month-old kid. Okay, what about a sling? So slings are again of type 1 and type 2 depending upon how much is the length and the narrowing. So as you can see here, there's a long narrowing here, and the bifurcation is low lying at T6. But what is the sling? Sling is, so this part of the pulmonary artery coming up from the right side and encircling the airways here or the trachea here. So this is a typically type 2 sling in which the carina is displaced inferiorly at T6 levels and you have a T-shaped appearance as well. So moving on from the long or the wide spectrum of a neonatal respiratory distress, which we talked about, both the medical as well as the surgical causes, let's look at another entity which is very particular and specific to children, which is the foreign bodies in children. So remember, foreign body aspiration is more common with food than toys. So children tend to pick up something and just put in the mouth, and at that age group, like 1 to 4 years, very typically, or 2 to 4 years. So as I said, highest risk is between 1 to 3 years of age. And the common foods are peanuts, grapes, candles, candies, and even battery ingestion is also particularly common. So if you do a radiograph, this is how a typical radiograph of a boy or a girl with a typical foreign body ingestion would look like. Many times history might not be forthcoming because the parents might not be in the same room, right? So what you can see here is a very hyperlucent or hyperinflated one particular segment and a distal collapse kind of appearance here on the radiograph. So typically acute respiratory distress, children can also come with respiratory arrest and cyanosis. So X-rays, what you need to do is a first inspiratory normal chest X-ray, even try to do a lateral one. So what happens? Okay, let's start with this radiograph. So you can see both lungs are well expanded. There is no focal collapse, consolidation, but there is slightly increased density over the left hilum, and this part of the lung appears slightly more hyperlucent. So this is a kind of equivocal kind of X-ray, and you are not sure. So ideally, you need to do an expiratory one, but in a toddler or a child who's 2 years or 3 years, you can't really ask the kid to do an expiratory or take a deep breath and do an expiratory one for you. So what is the next best step is do a decubitus ones. So at times you might have to do both decubitus, right or left lateral decubitus, once to see which side gives you a collapse pattern or a hyperinflation or an obstructive pattern first, right? So if you look at this decubitus U, we can also see now a radiopaque foreign body is demonstrated better now. It was not that well seen on the first one, the frontal radiograph that we see, right? And this also highlights the radiopaque foreign body here, showing the consequent air trapping and confirming the obstruction in that particular segment. So remember, in equivocal cases, you have to do an expiratory view, and toddlers cannot, so do a decubitus ones. So moving on from foreign body injections, the next entity would be a pediatric chest infections, which are also fairly common cause of a child coming to an ER. In fact, this is the most common non-traumatic pediatric emergencies. So what is the role of imaging in chest infections? So as a radiologist, our role is to determine the location, the extent, and look for complications. The main indications of most of the radiological diagnostic tools is to look for possible complications of children with infections. Most of the viral infections would not involve any radiology at all, and they kind of heal by themselves in 5 days or a couple of weeks' time. It's the complications we are more worried upon. So the chest radiograph is the most frequently performed radiograph in children, as in adults as well. So you start with a supine AP or erect view, depending upon the age of the child and the condition of the child, right? You can also do a lateral view if indicated. Many institutions do not follow a PA and a lateral view. I don't know what is the protocol in Thailand, but typically in India and many countries, you just do a one radiograph. But now the WHO guidelines also advocates 2 radiographs for children, a PA or AP, and a lateral view as well. So ultrasound is also widely used because there's no need for sedation, there is no radiation exposure, you can repeat it, it's a real time, it's portable and pretty cheap as well. And it helps you to pick up effusions, complex effusions, septations, loculi, and you can also differentiate between atelectasis and consolidations on a lung ultrasound as well. So as you can see here, these are two examples of effusions along with the lung collapse in a child who came with pulmonary infections to the ER. So CT scan and MRI are reserved for complications of infections. They are not routinely performed, and they can also be used to guide FNACs and biopsies. The disadvantages, of course, you might need sedations and the radiation exposure with CT scans. But specifically in conditions like adenopathy, if you want to look for lymph nodes, mediastinal hilar, CT scans is pretty specific. But you can also do a MR imaging for lung infections as well as lymph nodes. It does not involve any radiation. And for a child who is like more than 5 years can lie down in a MR machine without any sedation, I think it's the investigation to go by if you don't need sedation. So these are 6 different cases or examples of MR. We do a lot of MR for children with pulmonary infections in our settings. So this is a child with lung abscess and involving adjacent consolidation, another right middle lobe consolidation, centrilobular nodules in a child with tuberculosis. These are membranes in an hydrated and large lymph nodes in other kids with pulmonary tuberculosis. So MR can actually do a lot if the age group is right and you know how to optimize it. So there is a long list of bacterial pneumonias in children, and depending upon the radiographic pattern, which is by and large non-specific, but typically you see bronchopneumonias, hyperaeration, segmental or non-segmental or lobar consolidation and pneumonias. It's not very specific, so I won't go into too much details in this one. A quick word about pulmonary tuberculosis, which can be primary or post-primary. All the incidence is now coming down across the globe, but it's still there. Primary TB is seen in patients not previously exposed to Mycobacterium tuberculosis, infants and children less than 5 years. This can be parenchymal, nodal effusion, as well as miliary, but lymphadenopathy is the one which we want to diagnose early because it's the most common finding and important finding in a primary tuberculosis in a child. So you can do CT scan, which can show you multiple lymph nodes. You can do MR as well. Parenchymal lesions can be segmental or lobar distributions. You can have centrilobular nodules. Miliary TB, known as after the millets, right? So multiple small tiny nodules throughout, very specific pattern, which is again diagnostic even on a chest X-ray. Post-primary TB is another entity in older kids, but this involves upper lobes, consolidation, cavitations more commonly, right? Again, there is a long list of viral pneumonias in a child, which can range from influenza, para-influenza, RSV, adenovirus. By and large, they cause hyperinflation, consolidations, pneumonias to various degrees and resolve on their own. There are some specific entities which I'm going to show you some examples. One is round pneumonias, typically seen in children less than 8 years, solitary, well-defined borders, perihilar location, rounded in appearance, and after a follow-up, after a course of antibiotics, after 3 weeks, they just disappear, right? So as I said, it's the complications of pneumonia we are more bothered about, and these can include cavity formation, bronchiectasis, pneumothorax, empymas, effusions, fibrosing mediastinitis. This is where a cross-sectional imaging like CT and MR might be required, especially for follow-up of kids. And if these kids, some of them require surgery, you would need a cross-sectional imaging like CT and MRI. Some other causes of acute respiratory distress in children includes pulmonary embolism, trauma, and some tumors. Just to show you 2 or 3 quick examples of tumors in children. The first example, you can see this chest X-ray with the mediastinal widening and effusion on the left side. So this is a child with acute myeloid leukemia showing you mediastinal mass, and this is another child, 10 years old child, large mediastinal mass, which is typical for a lymphoma here. And if you have a chest wall or a bony lesion mass with a large intrathoracic component, think of Ewing sarcoma as well. Look at the ribs. If the ribs are destroyed with a large intrathoracic component, you're probably looking at an Ewing sarcomas. Again, in pulmonary embolism, you can do a CT angiography, which is the imaging investigation of choice in most of the institutions. But you could also do a contrast enhanced 3D GRE sequence for a pulmonary embolism in a child as well. So I'm going to quickly take you through some case-based reviews and spectrum. I'm not going to ask you anything. Let's see if you can do that. Look at case 1. I'm going to take 2 or 3 minutes. Supika, is that fine? Okay, thanks. So this is the first case. So you can see the pulmonary vasculature. It's oligemia. There's less vasculature, right? The aortic pedicle is narrowed, the cardiac size is enlarged, but this is a very typical appearance on a chest X-ray. So you have some cardiac entities in which you will have a very typical appearance, like an egg on one side. This is a box-shaped heart. So this is a corresponding a normal heart should look like, and this is enlarged cardiomegaly one with a box-shaped heart. So this is Epstein's anomaly, very typical, right? Decreased pulmonary vascularity. So this is different from this one, in which the vasculature is normal. The aortic root or the pedicle is again small here. The cardiac size is enlarged, but this is a purse ring appearance, pericardial effusion, right? Okay, so this one I showed you, a 7 or 8 years old child with a large solitary mass-like looking lesion on the first radiograph. So this is a round pneumonia. What about this one? A child comes to the ER, is taken up for a chest X-ray. You can see this opacity. This is the effusion on the left side, right? Effusion / empyema. So you can do an ultrasound after a chest X-ray and see a lot of complex septa, echoes, debris there. So this was the empyema in this child. What about this one? This is another cause of a respiratory distress in a child. So look at the ribs. Do they look normal to you? So this is asphyxiating thoracic dystrophy or June's dystrophy. This one we talked about. Yeah, diaphragmatic hernia on the left side. Yep. What about this one? This is a mediastinal mass, yes, lymphoma. What about this one? So the right looks okay, but there's an opaque left side, and this, I don't know if you can make out, the endotracheal tube is literally gone down, so there is collapse on the left side because of misplaced endotracheal tube, so you need to look at the tubes also very carefully. That can be another reason for the child coming with respiratory distress. So this is a newborn, a preterm kid. So if you have this hazy reticulogranular or opaque kind of appearance, this is a hyaline membrane disease, right? And the last one, 2 years old child with sudden respiratory distress and choking. One side lung looks very hyperlucent, right? So this is a foreign body, okay. So I would like to conclude by saying approach to a pediatric chest in the ER room depends on the age of the child, clinical profile. Chest X-ray is the first investigation to start with, which can be followed up by ultrasound if you're looking at pleural effusions or patterns of collapse at times as well. CT and MRI are reserved for congenital lesions, for pre-surgical road mappings, and for tumors as well. But always remember the ALARA principle while you are imaging the child to save the kids from radiation. And I would also like to take this opportunity to invite you all to the next AOSPR meeting, which is in Doha this year. Thank you.